Good morning, students, and welcome to NSC 306. So the facilitator is here. Her name is Olamejulo. So over to you.
Good morning, everyone. You are all welcome to today's online facilitation on NSA 306, Basic Maternal and Childbirth Nursing. I'm Mrs. Olamejulo Elinfumilayo. You are all welcome. Also, we are starting now on the NSC 306, as we have already discussed earlier on in our study session that we have had before. So this morning, we want to start from the introduction. The course is basically on the midwifery aspect of nursing and the anatomy and physiology of male and female reproductive system, under which we discussed the following: midwifery as a profession, historical development of midwifery, midwifery global practice, standard and regulations, female pelvis and fetal skull, female reproductive organs, male reproductive organs, hormonal cycle, fertilization, implantation, and development of fertilized ovum, the placenta, and the newborn. These are the topics that we have discussed so far during the time we are having discussions. So this morning we just want to go, one after the other on the study sessions. So we are starting with the midwifery as a profession. Next slide. Now, before we go that, I'll be coming. The question is the question breakdown. I want to tell you that we are going to be examining on all the study sessions that we have discussed. And the questions are in form of the filling in the gap, definition of terms, multiple choice questions, true and false formats. So meaning that to attend to all these questions, you need to read in between the lines. Also, you are going to write a short note. So you have to read in between the lines so that you'll be able to pick on all the questions and answer them appropriately. I wish you success. Now, let's start on the definition of midwifery. According to International Confederation of Midwives, a midwife is a person who, having been regularly admitted to a midwifery school, a midwifery educational program, fully recognized in the country in which it is located, and has successfully completed the prescribed course of studies in midwifery and has acquired the requisite qualification to be registered and or legally licensed to practice midwifery. So for being a midwife, meaning that you have to have, gone to school of midwifery, either on basic form or post-basic. I want to tell you that even before you can go for this, you need some requisites. You have your basic O-level, 5 credit O-level, including English, mathematics, chemistry, biology, and physics. If you are going for basic midwifery in Nigeria, then if you are going for post-basic midwifery, you must have qualified as a registered nurse. No any other field except nursing. Registered nurse, then with your basic O-level, 5 credits O-level. Now, this one will qualify you to go to the school. After finishing the course, the basic midwifery is for 3 years in Nigeria, while the post-basic midwifery is 18 months in Nigeria, in our country here. So after the course now, after you might have completed your course, you sit for the final qualifying examination, you pass. After passing, then you'll be registered in the register of Nursing and Midwifery Council of Nigeria, and then you'll be licensed. That is the time you have fully become a professional midwife, and you are licensed to practice anywhere in the world. And during the time you will be practicing, you have some activities that you have to undergo. And some of the activities are to provide sound family planning information and advice to your clients. Then to diagnose pregnancies and monitor normal pregnancies. To carry out examinations necessary for the monitoring of the development of normal pregnancies. You are also to prescribe or counsel or advise on the examinations necessary for the earliest possible diagnosis of pregnancies at risk. That is high-risk pregnancies. So you are being, fully equipped to do all this. So far, you are you are a professional midwife. Furthermore, as a midwife, you need some role to perform. Aside the activity that you are doing, you need to perform certain roles in the community where you are residing, in the society where you are living, in the country or the town that you are residing. You need some role because you'll be interacting with people in your community, in your society, in your workplace. What are then these roles? You have preventive measure. You should know how to prevent some condition that may be injurious to your client before it occurs. Then you need to promote a normal birth. That is, your client must deliver a normal baby without any complication whatsoever. Then you should be able to detect any complications in the mother and in the baby, either during pregnancy or immediately after birth. Then you must be able to assess medical care or other appropriate assistance and carry out emergency measure, because you have been taught when you are in school to do all this. These are the roles of the midwife, to mention but few. You have every other thing inside your manual. Am I talking? Now, let's go to historical development. When you talk of historical development, it's talking about the genesis of midwifery. How Genesis come into play in the whole world, right from the ages. That is what we are talking about. And I want to tell you, this historical era development has so many eras. And I want you to know something. Midwifery is the first holistic profession in the world. What do I mean by this? That is, midwifery is the first profession that is recognized first in the whole world, and it's a holistic profession. So that is what actually makes it, different in nursing profession and in other professions all over the world. Then midwifery started during the Stone Ages. And during these Stone Ages, it is divided into three. That is Paleolithic period, Middle Stone Ages, and Neolithic period. During the Paleo, there are some particular things, some spectacular things that occur in each of these eras. Like this Paleolithic period that we are talking about. Pregnancy and childbirth during the Paleolithic era were processes that require women to survive labor in a high environmental lifestyle. Then, during birth, women are the ones that are supporting each other during birth. And they are supporting them based on the knowledge and skill they gain from observing other mamas. Knowledge and skill, not this, knowledge and skill that they gain from observing other mamas. This is what they were using to manage any woman in labor successively. And further that, during the Paleolithic period, they prepared for labor by getting into a squatting position. I believe you know what is meant by squatting position. Leaning down, somehow, just like somehow leaning down. And they cut the umbilical cord. They initiate breastfeeding as we are doing now. They were doing all this then too. And they also create a warm and safe environment for newborn. Hello, are you there? conceptively, which are involved supporting, it supports a natural and safe birth. Paleolithic period. You know, we are clamoring for, you know, natural birth now. It has started then, right from the Paleolithic period. So we are going back to it now. So supporting women in labor naturally, to have a natural labor, it has started long ago during the Paleolithic period. Furthermore, the male role focus during Paleolithic period, the male role focus on maintaining family security, while women gave back and manage their labor. So during the Paleolithic period, male are supporting women. They are giving them a security during the time they are in labor and manage their labor alongside with other women. That's all about the Paleolithic period. So when we talk about Middle Stone ages, men remained and provided help for their partner, particularly during labor, meaning that the male's role became more inclusive because of the need to combine their role with long journey. So they provide help for their partners, particularly during labor. They still continue to support the women in labor. And then during the Neolithic period, the male's role was totally excluded, particularly, and it continued to be safe throughout about 10,000 years. Then men's role and energy in this era mainly focused on the adjustments related to the evolution of agriculture and associated technology. As a result of this, old women were the main attendants at birth and gradually started fulfilling the role of a midwife. So during the Neolithic period, the men, they majorly focus on agriculture, while old women in the family, in the community, were not taking care of delivery of the woman in labor. Can you get this? So during the Neolithic period, old women were the one taking care of the delivery. They are the one attending to the delivery, because men, they now focus on agriculture. Then during the biblical era, midwifery during the biblical era was a respected social practice performed by women of childbearing years. Their role focused on managing normal pregnancies and delivery. And they were skilled in vaginal examination and in divining the gender of a fetus during pre-breech presentation. So also, midwife during the biblical era initiated the use of bathing stool. They invented bathing stool. That is, these two, it was the one that women in labor, they were resting upon by the time they are in labor. So it was during the biblical era that this bathing stool was invented. And this bathing stool too, they used it for about 3,300 years. So also, the biblical era was the golden period in the history of midwifery, in which women empowerment had an active role in framing some concept of professionalism in midwifery. We want to talk about the family center care. I want to tell you that family center care were also initiated during this era. During the biblical era. Family center care that we are clamoring for now has long started right from the biblical era of midwifery. So they are during this period, they initiated this concept, and we are still using it today. And when you are talking of family-centered care, it means that you want to care for the woman in labor, you want to care for the pregnant woman, you want to care for her during her labor, you want to care for her husband, you want to care for the children on ground, and you want to care for every other members of the family that surrounds her. So you are not concentrating your care on the pregnant or laboring woman alone. You care for every other members of the family. So you carry them along. This is what you are planning for now. That whatever care that you are giving to your client, you need to carry the family alongside. So it has been, in existence for long. We have some other eras too, like midwifery during Egyptian era. During the Egyptian civilization and social construction were the main macro-social factor that shaped midwifery as a unique social and female vocation. We have a lot of these, but I want you to please go over them. We have about 9 eras. Midwifery during the Egyptian era, midwifery during Greco-Roman era. Are you with me? Okay. Yes, definition of midwifery is the next one. Okay. Midwifery during the Byzantine era, midwifery during the High Middle Ages, midwifery during the modern era, when midwifery and men midwifery were introduced. Midwifery and nursing during the modern period. And these are all the eras of midwifery. So I want you to go over there and know what is peculiar to each of the era. You understand? I hope you are with me. Okay, thank you. So let's now go to the definition of midwifery practice. That is, when you talk of midwifery practice, the practice of the prevention of midwifery is defined as the management of normal pregnancies, childbirth, and postpartum care, as well as primary preventive reproductive health care of essentially healthy women, and shall include newborn evaluation, resuscitation, and referral for infants. So midwifery practice is telling you all these practices after you might have gained the theoretical aspect of the midwifery and you are registered and licensed to practice midwifery. It's now talking about the practices that you'll be undertaking. That is, you should be able to manage normal pregnancy. You should be able to, deliver a child autonomously. Then you should be able to care for this one that has been delivered, postpartum care. Then you should be able to give preventive reproductive health, like family planning, sexual education, right of women, all sorts of things like that. You should be able to do this because you have been taught. And you should be able to examine and evaluate a newborn and resuscitate any child that has any problem. And also, if you feel that you cannot manage such a child, then you should be able to refer such a child to a newborn to a place where the baby can be effectively managed. Then, what is ethics? I think definition of ethics. You were taught, you discussed, ethics at length yesterday. I think in NS310, the ethics were discussed at length. But at the same time, midwifery has its own ethics. That is why Rushworth Kidder states that the definition of ethics in midwifery, a definition of ethics is just the science of moral duty. Science of moral duty. At the same time, it can also be defined as the basic concept and fundamental principles of decent human conduct. Basic concept and fundamental principles of decent human conduct, normal conduct, decent conduct, loyal conduct, moderate conduct, professional conduct within your jurisdiction. It also includes study of universal values such as essential qualities of all men and women, human or natural rights, obedience to the law of the land, concern for health and safety, and increasingly also for the natural environment. So when we are talking of ethics, is talking about the moral obligation that is expected of you when you are performing your duty at your workplace. That is the respect that you must have respect for your clients. Everything that she tells you, you must not disclose it to any other person. Then you must equalize fairness. You must treat everybody equally. Although we are still going to that. These are the ethical principles. You understand? So when you talk of ethics now, we are talking of expected moral obligation from you. What are the things that will not judge you, that will not guide you? These are the ethical principles. That is autonomy, beneficial, non-malfeasance, and justice. When you talk of autonomy, that is the client has the right to decide whether she wants what you want to give her or to reject it. So you cannot coerce. You must not force your client. You must not coerce her. You can only, cancel her. These are the things. These are the alternatives that you have. You can pick the one you want, but you cannot force it on her. And when you talk of beneficial, it's talking about the benefit that the client will get from the care that you are offering her. So you must not do anything that the patient will not benefit from. Then non-malfeasant, you should not do harm. You must not injure your clients in any way, in any form. How minute it is, you need to manage them effectively so that they do not, injured in any way. Then justice, you must be fair in delivering your care. What you do for A is what you are going to do for B. You share everything equally. No presidential treatment. We are all human beings. So thank you at that level. So let's now go further. The female pelvis and fetal skull. I told you that it's talking about the evolution or genesis of midwifery and reproductive organs of both male and female. So we are now going to the reproductive aspect of it, the anatomy of reproductive organ in both male and female. So let's start with the female pelvis. Female pelvis and fetal skull. During our discourse, we talk about the type of female pelvis. And I believe that we have 4 types of female pelvis. The gynaecol, the android, the platyploid, and the other one, making 4. But at the same time, we still have some deformed pelvis. This is a legalis pelvis and robot pelvis. This one, normal labor cannot take place with this type of pelvis. But with the first 4, we can still have normal labor. But the one that is more favorable for normal labor is gynaecol pelvis. So you must have the understanding of this. Then we also talk about the ligament of the pelvis. You know the ligament, sacrotuberous. All these, there are about 4. We talk about them, about these pelvis ligaments. Then diameter of the pelvis. They are also very important. Diameter of the brim, diameter of the outlet, and the diameter of the cavity. We discuss all the 2. Then pelvis landmark. When we are talking of pelvic landmark, pelvis landmarks are those structures in the pelvis, either in the brim, cavity, or the outlets. all these landmarks, they have important things they are doing. They are not just there ordinarily. When you talk, part of them is sacral promontory that is found on the sacrum bone. And you know, it's projected, meaning that if it is too projected, it will reduce the anteroposterior diameter of the rib. Another one is ischial spine, this one is located on the ischium bone. And you know what it's meant for. It shouldn't be prominent. If it is prominent, meaning that it will reduce transverse diameter of the outlets. We have lots of them like that. You must know them. Then we talk about the innominate bone. The innominate bone, there are two in number. These are the bones that make up the pelvis. The bones that make up the pelvis are the two innominate bone, the sacrum, and one coccyx. The innominate bone, we have two of them, and they join together at the back of the pelvis and in the front of the pelvis. So the innominate bone is made up of three bones: the ilium, the ischium, and the what? Ischium. And the pubis. And the pubis. So all these, they come together. The two of them come together to form to form the pelvis. We also discussed about the joint of the pelvis. And we have four joints of the pelvis. Two sacral ilium joints, one symphysis pussy bone, and one sacrococcygeal bone. They are all there performing important role, especially towards the end of pregnancy. They give way so that the pelvis become roomy and enable the baby to pass through. We went further by discussing the muscles of the pelvic pelvis, both superficial and deep. The superficial pelvic muscle, there are 5 in number, while the deep superficial and deep pelvic muscle, there are 3 in number. The deep pelvic muscle are the ilium, iliococcygeal, ischiococcygeal, and pubococcygeal. All these, they are also called what they are called levator ani muscle. And they are being pierced by 3 holes: urethra hole, vagina hole, and anus. Then superficial, they are the one found outside. So the superficial muscle, there are 5, as I've said, under which you have sacrotuberous muscle. Coming, this will hold. The external sphincter, the transverse perineal muscle, the bulbocavernous muscle, the ischio-cavernous muscle, and the membranous sphincter of the urethra. Please, you must know the beginning and where all these muscles end, where they arise from and where they are inserted to. You understand? And we went further by discussing the perineal body and its measurement. The perineal body is a triangular muscle that is located between the vagina and the rectum, and it has a dimension, I think 4 by 4, 4 centimeter by 4 centimeter is the dimension of the perineal body. What is it doing? It's open. This is the muscle that we are cutting by the time we are giving episiotomy during labor. Can you get what I'm saying? I said perineal body is a triangular muscle located between the rectum and the vagina, and it measures 4 centimeter by 4 centimeter, and the apex is located superiorly, inferiorly, while the apex is located superiorly. Are you all there? These are all about the muscle. And I want you to know the nerve supply to all these muscles that we have mentioned. To all the muscles, to all the ligaments that you have mentioned. You must know the blood supply and nerve supply to them. You understand? So let's now go to female reproductive organ, both internal and external. The internal reproductive organ, a female reproductive organ, includes the uterus, the ovary, the cervix, and the vagina. So the uterus, when we want to talk about the uterus, macroscopic structure, we want to talk about the size of the uterus. That is, the size of the uterus is 7.5 centimeter in length, 5 centimeter in breadth, and 2.5 centimeter depth, and 1.25 centimeter in thickness. It is located in the true pelvis and has a half-pear shape. Located in the true pelvis, maintaining anteverted and anteflexion position. Meaning that anteverted meaning that is leaning forward, and anteflexion meaning that is resting on the bladder that is located in front of it. These are the macroscopic structure. We want to talk about the size, the shape, the location, and the position. Then microscopic structure, that is the muscle layers of the uterus. From internal outward, there is an endometrium, which is the first layer. This one is made up of epithelium, mucus and goblet epithelium that secrete mucus and nutritious element that nourishes the fetus if pregnancies occur. Then myometrium is the second layer, and this one is made up of muscle layer, the outer longitudinal, the oblique muscle fiber, and the inner circular. The circular is located towards the cervix. All these muscles, they have what they will do or they are doing. That is why they are located longitudinal, oblique, and circular. Then the last layer is the perimetrium that cover and secure and protect the uterus. Then what is then the function of the uterus? It carries pregnancy. From the day the pregnancy occurs, conception occurs, till the woman falls into labor and expelling it. It also partake in the menstruation. You understand? At times you use uterus for family planning by insertion of the IUCD. Are you there? These are the function of the uterus. Then what is the blood supply? The blood supply to the uterus. The blood supply to the uterus is what? Please go and read that. Go and read blood supply to the uterus. Then we want to talk about the fallopian tube. The fallopian tube, there are two in number, each located at the fundus of the uterus, at the corner. And the length of each is about 10 centimeters. And the fallopian tube is divided into 4 parts. The infundibulum, the ambulum, then the isthmus, and the cornu parts. You should know all these parts, and you know the function of each part. Structural, microscopic structure of the fallopian tube. This one from outward, inward, we have the perimetrium as it covers the uterus. Then the thin muscle layer, and the last layer, which is epithelium layer. It consists of ciliated epithelium. And the purpose of cilia there is just to waft the fertilized ovum from the ampulla down to the uterus for implantation. after fertilization. Then the ovary. We want to talk about the size of the ovary, the shape, the functional part, and the blood supply to the ovary. The size of the ovary. The ovary size is about 4 centimeter by 1.5 centimeter. Are you there? Please check that one inside your okay. Then the functional part, the shape is almond shape, and the functional part is the cortex. And the blood supply is from ovarian artery. Then you want to talk about the cervix. You know, the cervix and the uterus, they are together. So the cervix is located at the lower uterine segment and taking about 2.5 centimeter in length. Then the vagina, the length of the vagina and posterior wall of the vagina. The vagina is a hole up that is in a position, and it commences from the vulva down to the cervix. And at the end, upper, it forms the fornix. That is, the fornix is the receptacle for our cervix. And we have 4 fornices, 2 lateral fornices, 1 anterior and 1 posterior. They are the one in which they are the place where the cervix is resting upon. And vagina is partially S-shaped. This is what actually makes the anterior surface, anterior part of the vagina to be shorter than the posterior. So that is what makes the posterior part of the vagina to be 10 centimeter and the anterior part to be 7.5 centimeter in length. And at the same time, vagina has no secretion of its own, but it uses the secretion that comes from the cervix. You know the layers of the vagina too. The layers of the vagina, it continues with that of the layers of the cervix. That is squamous epithelial cells. And you know the color of the squamous epithelial cell is white, and it extends down to the vagina, followed by the muzzle layer of longitudinal and circular. Then followed by the perimetrium covering it. But the inner layer, which is squamous epithelium, it is whitish in nature. This whitish in nature, in conjunction with the acid, with the secretion from the acid, then dodderling bacilli, which is normal flora in the vagina, now act upon this squamous epithelium to produce a secretion. And this secretion is acidic in nature, about 4.5 pH. And they provide acidic medium for vagina, protecting the area from infection of microorganisms. That is why a woman, a pregnant woman will come to you, you ask, do you have any vagina coming out from your vagina? She will say, yes. Then what is the color? She will tell you white. Anything aside white denotes infection. White secretion discharge during a pregnancy is normal because of the action of a dodderling bacilli on the squamous epithelium that lines the vagina. And the purpose that is serving there is producing acidic medium that prevents the infiltration of microorganisms. Now let's go to the external genitalia, which is vulva. When you want to talk of external genitalia or vulva, we want to talk about the labia majora, which is 2, 1 in each side, left and right. This one is followed by labia minora. And within the labia minora, we have the vestibule. The vestibule is just a oval-shaped structure that houses the urethra oribus and vagina oribus. Then you also have the clitoris, which is synonymous to male pelvis. due to the presence of erectile muscle that is inside it. So it's synonymous to penis in male. You understand? Then you also have the prepuce, where the labia minora, where they join together superiorly. And you have the vestibule, where they join together superiorly. That is how we have the perineum. Then vaginal opening in female, especially before puberty or at puberty or after puberty, is always closed by an hymen. It's always closed by an hymen. But after the first intercourse, this vaginal hymen is ruptured and left with a scar known as a multiform nest. Caruncle multiform. This is the name of the hymen when it is ruptured after first sexual intercourse. So urethral opening is located about 2.5 centimeters below the clitoris. And below the urethral opening, you have the vaginal orifice. Then let's now go to fetal skull. Fetal skull. When you talk of the fetal skull is the hardest part in the fetus. And the bone of the fetal skull developed from the membranes. The bone of the fetal skull developed from the membrane. And ossification starts as early as the 5th week following conception. Ossification starts following a 5th week following the conception. The fetal skull is made up of the foot, the face, and the base. The foot is made up of about 5 bones, 2 frontal bone, 2 parietal bone, and 1 occiput. Then the face consists of 14 bones, but they are fused together. So they are immovable. But the fetal skull, the fetal bone, the skull, the vault, the bone of the vault, they are a bit movable. Then you want to talk about the base. The base consists of ethmoid and sphenoid bone, but you cannot see that one outside. They are located underneath the edge. Then sutures of the fetal skull. When you talk of the sutures of the fetal skull, they are the membranous sheets that are located between the 2 bones of the fetal skull. Therefore, we have labdunda suture, which is found between the occipital bone and the 2 parietal bone. The sagittal suture located between the 2 sagittal bone. Then coronal suture, which is located between the sagittal bone and the frontal bone. And you have frontal sutures, which is located between the 2 frontal bones. Then you want to talk about the fontanelle. The fontanelle, these are the area, these are the points at which all these bones meet anteriorly and posteriorly. We want to talk about the anterior fontanelle. Anterior fontanelle is a kite shape or diamond shape, and it's about 4 centimeters in length. And this is where the parietal bone, frontal bone, they join to sutures, they join together, they meet. Then, when you talk of posterior fontanelle, this is the fontanelle that is located between the occipital bone and the 2 sagittal bones. The anterior fontanelle, this one closes at 18 months after delivery. 18 months of baby, when the baby is around 1.5 years, that is the time this anterior close will close. And what do you find in this anterior fontanelle? They are the blood vessels now supply. They meet at the junction where all these sutures meet, and they always pulsate. You see that the anterior fontanelle always pulsate. What makes it to be pulsating is just the presence of blood vessels that cross each other there. You know, blood vessels supply all this bone that you are talking about. All these blood vessels, they now cross and they meet at the anterior fontanelle and they are pulsating. And they continue to pulsate. You continue to feel the pulsation until 18 months after the delivery of the baby. When the baby is around 1.5 years, that is the time the area will now close. You will not see it as a depression. The area is there. But the posterior fontanelle, that one closes at 6 weeks of birth. Then you want to talk about the diameter of the fetal skull. This one is very important. You know, we have anterior posterior diameter and the transverse diameter. Under the anterior posterior diameter, we have lots of them over there. Among them, you have sub-occipitobregmatic diameter of 9.5 centimeter. The sub-occipitobregmatic, you know, begins from the below the occiput and end at the anterior fontanelle. It measures 9.5 centimeter. This is the best for the centimeter for delivery. Any centimeter, any presentation above or lower than this, the individual will have a problem at delivery. The baby might not be able to pass because this is the most vulnerable diameter. Then you want to talk of occipitofrontal, which begins from the occiput bone down to the frontal bone, and that one is 10 centimeter. Then sub-occipitofrontal of, you know, below the occiput down to the frontal, 11.5 centimeter. Then sub-occipitobregmatic, sub-mentobregmatic, which is also 9.5 centimeter. This is the presenter, the centimeter that presents during the first presentation. It's also 9.5 centimeter. Then you have mentovertical, which begins from the chin to the highest point of the vertex. This is about 13.5 centimeter. Then submentovertical, which is also, you know, 11.5 centimeter, begins from the below the chin to the highest point of the vertex. All these diameter, they are very important. These are the anteroposterior diameter. When you talk of the transverse diameter, you want to talk of bitemporal diameter, which is about 8.2 diameter, a centimeter in diameter. And then you want to talk about the biparietal, which is 9.5 centimeter. All these diameter, they are very important because the diameter of the fetal skull and the diameter of the maternal pelvis, they must commensurate each other. If one is higher than the other, or one is shorter than the other, there will be problem at delivery. Let's now go to breast. Breast, gross structure of the breast. The female breast is otherwise known as mammary glands, and it concerns with lactation. It's concerned with lactation after delivery. And it is situated between the second and sixth rib on pectoralis muscles. It is located at the chest region between the second rib and sixth rib on the pectoralis muscles. I want to tell you that the size and the shape of the breast varies in individual. Then, what is microscopic structure? The breast has about 18 to 20 lobes, and these lobes are divided by visual. And each lobe is also divided into lobes that consist alveolar. This alveolar that we are talking about is lined with acidic cell. Inside the acidic cell, you have the myoepithelial cell that secretes milk. So, after the milk is being secreted, a tube will now connect it. We collect the milk and take it to where? It will take it to the ampulla. So, lativorous tube will connect the alveolar and collect milk to the ampulla. What is then the blood supply to the breast? The blood supply to the breast is from mammary artery, branch of intercostal muscle, and the correspondence vein drains it. Are you there? Thank you. So that is all about the female reproductive system. Let's now go to male reproductive system. Male reproductive organs include the scrotum, the testes, seminiferous tubule, epididymis, vas deferens, ejaculatory duct, and urethra. These are the ones that are related, that are peculiar to the production and movement of spermatozoa. Others are the accessory organs. We'll get there. Then what about the testes? You want to talk about the testes? The testis is located outside the body, underneath, and it is found inside the scrotum. It is located at the lower part of the perineum, inside the scrotum. The size is about 4.4 to coming. Okay. Testes are the male gonals, male reproductive glands, and produce spermatozoa and testosterone. Testosterone is the hormone responsible for the secondary sex characteristics. Along with the follicle-stimulating hormone, it promotes the production of sperm. Then, in order to achieve their function, the testes must remain below body temperature, and hence they are situated outside the body. And each testis is rounded body measuring 4.5 centimeter long, 2.5 centimeter wide, and 3 centimeter thick. These are the dimensions of a testis. And it is composed of several layers of tissues, starting from tunica vasculosa, which is an inner layer, tunica vaginalis, the outer layer, and the seminiferous tubules, the portion where spermatogenesis or production of sperm takes place. So spermatogenesis takes place in the seminiferous tubule. And I want to tell you that it takes about 70 to 80 days for a spermatozoa to mature. And in its movement along all this structure, the normal sperm move at a speed of 2 to 3 millimeters per minute. That is why it takes about 70 to 80 days for a spermatozoa to mature. Look at the movement, 2 to 3 mm per minute. So it will take about 70 to 80 days before it can mature. Then testis produces spermatozoa and testosterone. And interstitial cells produces testosterone. Interstitial cell is located inside the seminiferous tubule, and is the one that produces the testosterone. Then what is the function of testosterone? Testosterone is responsible for male secondary sexual characteristics, like breaking of voice, coming out of here from the armpit and the chest of male, and the pubic area of male. This is what the testosterone is responsible for. Then let's go further. We want to talk about epididymis. Epididymis is a comma shaped. I mentioned it here. Epididymis is a comma shape. No any other. C shape. So, and it lies on the superior surface and extends down the posterior aspect of the pole of testis. where it leads into the vast difference of different ducts. And what happens in the epididymis? Already matured sperm, when they are now produced, they are yet to be ejaculated. They will be stored inside the epididymis. Then, when they are about, during the ejaculation, after storing it there, when it is ready to move out, it will move into the phase difference or spermatic cord before getting to ejaculatory duct. It's ejaculatory duct that will eliminate the spermatozoa via urethra. There are some other organs that are in support of the movement and nourishing of the spermatozoa. They are called accessory organs of male reproductive organ. And they include seminal vesicle, prostate gland, and bulbourethra. They are accessory because they are not participating primarily in the production of spermatozoa. But they secrete some fluid which help in the motility of the spermatozoa and nourishing of spermatozoa. So without them, spermatozoa may not be able to move as it's supposed to move before it dies off. But with their secretion, spermatozoa will be able to move freely. Furthermore, there are some environmental factors that affect the sperm production. Now, I told you that testes, they are not located within the body of a man, but they are located outside at the perineum area, at the lower portion. If they are located, they may die off due to high temperature. Testes need cool temperature that facilitates production, spermatogenesis. So, as a result of this, there are some factors that may affect the sperm production, which include overcrowding, smoking, stress, radiation, poor nutrition, modern clothing, and pollution. You know, where there is overcrowding, what will happen? There will be heat there. Smoking, what will happen? Heat will be generated. Stress, heat will be generated. Radiation will kill off even the testes totally. An individual that is not taking enough food, will it be able to have enough strength and power? Then modern clothing that we are wearing these days, tighties that we are wearing, especially male, they shouldn't wear tighties. That is why they are wearing these sporties. You know that sporties are loose. They are loose. So they allow fresh air to go in to the testes. So they shouldn't wear tighting materials. Then pollution, when the environment is polluted, either with smoke or whatever, it can cause, it can delay or prevent spermatogenesis to take. That is, then the individual will end up what? Will end up with infertility. Will not be able to provide to produce a fertile sperm that will fertilize or matured sperm that will fertilize the ovum. Let's go further. I hope you have gotten it to that level. Thank you. So let's go further. Ovular cycle. When you talk of ovular cycle, you want to talk about the ovarian cycle, you want to talk about the ovulation, you want to talk about the ovarian hormones, and you want to talk about the menarche and menopause. What do you understand by the ovarian cycle? The ovarian cortex at back contains about 200,000 primordial or rudimentary follicles from puberty onward. Certain follicle enlarges and will mature each month to liberate an ovum. A matured ovarian follicle is called Graafian follicle. A matured ovarian follicle is called a Graafian follicle. So the life cycle of a Graafian follicle, the ovum is situated in one side of the Graafian follicle and is enriched by the narrow periphytellin. Surrounding this lies a clump of cell called the discus progellis, which radiates outward to form the corona radiata. The innermost cells of the corona are referred to as the zona pellucida. Zona pellucida. The whole follicle is lined with granulosa cells and contains follicular fluid. The outer coat of the follicle is the external limiting membrane, and around this lies an area of compressed ovarian stroma known as the theca. So after the matured ovum, when the matured ovum reach the edge of the Graafian follicle, mature one is called Graafian follicle. After the mature one reaches maturity, this Graafian follicle is now called Graafian follicle, as I've said. And then the cysts that cover the ovary will burst. When it bursts, what happens? Ovulation occurs. Do you get what I'm saying? Ovulation will occur. So as soon as the ovulation occurs, and then the sperm is being produced by man, and ejaculation takes place. When it meets with the liberated ovum, fertilization will take place. When fimbriae end of the fallopian tube pick it, take it to the ampulla area, and it meets with the spermatozoa, then fertilization takes place. Then I want to tell you that ovulation usually occurs in a cycle, in a woman with a cycle of 28 days. Ovulation will occur on the 14th day. In a woman with a cycle of 28 days, ovulation will occur on the 14th after menstruation. But any other woman which with varied cycle of menstruation, probably 30, 32, 35, then their ovulation will occur 14 days to the next menstruation. You know, their own is not 28 now. It might be 30, it might be 32, 31, 33, 34, 35. That is the list. So 14 days to that date, they will ovulate, they will start menstruating, is their ovulation day. But with a woman with regular 28 cycle, is on the 14th after menstruation. When the menstruation begins today, start counting 1, 2, from day 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. On that 14th day, ovulation will occur. Counting from the beginning of menstruation, day 1 of menstruation. For anyone that is not having 28-day cycle, ovulation will occur 14 days to the next menstruation. I believe I'm talking. You get it clear? And I want to sound it to you that fertilization is most likely to occur when intercourse takes place around the time of ovulation, within 48 hours prior to 24 hours following ovulation. It is the fusion of both male and female gametes that forms zygotes. And during the intercourse, about 2 to 4 mils of semen, which is spermatozoa, containing 60 to 100 million of spermatozoa are deposited into the vagina. 2 to 4 mils of semen, and each mil of that semen contains about 60 to 100 million of spermatozoa are deposited into the vagina of a woman. Then implantation. After fertilization, implantation will occur. Implantation means that the fertilized ovum, which is zygote, continues its passage through the fallopian tube and reaches the uterus in 3 to 4 days. During this time, it undergoes segmentation or cell division to form blastomeres. When the blastocysts fall into the uterus, which is about 11th day after ovulation, after fertilization, it lies freely for 2 to 3 days. Then the part of a trophoblast that lies over the inner cell mass then become quite sticky and adhere to the endometrium. Then inner cell mass, by the time, let me explain this area very well. By the time segmentation is taking place, the zygote begin to divide into 2 to 4 to 8 to 10, to 12, and so on and so forth, until cluster of cells is formed called morula. That one will take about 3 days after fertilization. Thereafter, this morula fluid, start to accumulate inside it and divide these cells into 2. One cell to one part, to one pole, and the other one to one pole. At this stage, when the fluid is inside the morula, it is called blastocyst. It has the blastocyst level that it will reach, it will fall, it will stumble into the uterus for implantation. So, and it will lie freely for 2 to 3 days inside the uterus before this implantation occur. What is the implantation? The blastocyst will find a way. We erode the endometrium. And it will dig deep down into the basal layer and cover itself with also endometrium. So you cannot see it inside the uterus because it has been covered up. This is what we call implantation. And during the time of implantation, that I tell you that blastocyst, it digs the endometrium layer. By the time it's digging it, some blood vessels will be some blood vessels, they will rupture. So at this stage, the woman will now see bleeding. When you see small bleeding coming from this ruptured, blood vessel, it will take it to be a menstruation. When in fact it is a implantation, embedding bleeding, embedment bleeding. That is what is called embedment bleeding. So it's not just a drop of blood. It's not, a real menstruation. So, but some women will take it, they make mistake calling it a menstruation. Then, after the implantation, embedment, then, I told you that the cells inside the blastocyst, they divide into 2, one to each pole, another one go to another pole. The one that goes to the other side are called inner cell mass. The inner cell mass is the one that will form the fetus and the amnion. Why the other one to the other pole called trophoblast is the one that will develop into placenta. And the function of the placenta is the one that will be feeding the baby when it is fully matured. Are you getting it? So inner cell mass will develop to form the fetus and the amnion, and the trophoblast develop to form placenta and chorion. So deciduum beneath the site of implantation is called deciduum basale. Deciduum, the area where that fetus, where that blastocyst that embedded is, staying up, is leading up, is called deciduum basalis. It's called deciduum basalis. So, and the baby continue to grow and grow and grow and grow like that. Then ovarian ovules. What are the ovarian ovules? The ovarian ovules, these are the hormones that are being produced by the ovary. And we have 3 types of them. Number 1, estrogen. Number 2, progesterone. And number 3, towards the end of pregnancy, relaxin will be produced. And you know the function of hormones, estrogen and progesterone. If the woman, menstruates, probably she has the intercourse, and unfortunately, fertilization does not take place, or he doesn't have any intercourse, and fertilization does not take place. That means that she will menstruate. So immediately menstruation ceases, or even at the time the menstruation is still going on, hormone will be produced known as estrogen, with the help of a follicle stimulating hormone and utilizing hormone from the anterior pituitary gland. They will now have effect on the corpus luteum. Corpus luteum is the remnant where the ovum, remnant of ovary, where the ovum has been liberated or released. So it's corpus luteum. Is this corpus luteum that will be producing estrogen if pregnancy occurs? And if the pregnancy does not occur, the corpus luteum will regress and become white body. It will not be called yellow body. But if the pregnancy occurs, it will be called yellow body. You understand? And it's one that will be secreting estrogen. The estrogen will continue to be secreted, and the estrogen will go to the uterus. So far, there's no fertilization. Nothing is coming into the uterus. It will now start to prepare the uterus for another ovulation. We now start preparing the uterus, all the layers that have been shed during menstruation. We now be repairing it, bringing it back to normal. The mucus will be secreting, the nourishing thing will be secreting, and the endometrial layer of the uterus will now be regenerated. So also, progesterone will also be produced by estrogen. If the pregnancy does not occur, it will also go there. The progesterone will go there to hold the integrity of the uterine endometrial layer. It will go there to hold the integrity of the uterus endometrial layer. And I want to send it to you. During the proliferative phase is a phase that follows the menstruation phase. And during the proliferative phase, the estrogen is being produced by the corpus luteum that will nourish the endometrial lining of the uterus. And during the secretive phase, which is the second phase of menstruation, progesterone is the one that comes into play. So these are the hormones that happen. Then relaxin is also produced by the ovary, but it occurs. Relaxin is being produced if the woman is pregnant. It is produced towards the end of a pregnancy, purposely to relax all the ligaments that hold the pelvis, in position. It will relax it. When it relaxes it now, the pelvis will become large. It will gain. It will create more room for the baby to pass through. Because if these ligaments are not relaxed, there's no way for the baby to pass through, because the area will be too tight for the baby to pass through. But as soon as the relaxing comes into play, working, it will relax the ligaments, and the ligament will be loose. All those things that they are holding together, the muscles, the bones that are holding, they will be also loose. And so they will create more room for inside the cavity of the pelvis, and the baby will be able to pass through it easily. Then the menstrual cycle. I think I've mentioned that the menstrual cycle, begin with the menstrual phase. It has a 3 phase: the menstrual phase, the proliferative phase, and the secretive phase. And the proliferative phase is divided into early and late proliferative, but almost the same thing. The menstrual phase is the first to 3 days of menstruation, when the fertilization does not take place and menstruation, the endometrium is shed. all the layers of the endometrium, especially the functional layer, will be shed. The dead ovum will also be shed, and the ruptured blood vessel, they are all shed as blood, called menstruation. And that one will occur in 4 to 3 or 5 days. It differs in the individual. Then the second phase is proliferative phase. This is the regenerative phase of the linings of the endometrium. You know, during menstruation, the endometrial lining, the functional part has been shed, has been removed. So we want to repair it. The estrogen will now be working on that, repair all those broken vessels, all the broken endometrium, the epithelium that has gone is one that will be nourished them again, they will regrow again. Then the progesterone will also come into play at the secretory phase, secreting, you know, and holding the integrity of the uterus, endometrial lining in position. It does not shed. Because if the woman eventually becomes pregnant, if the progesterone is not produced, then the woman may have abortion. We'll discuss that later. That is all about the menstrual cycle. When you want to talk about menarche and menopause, the menopause, the menarche, what do we understand by the term menarche? Menarche is the first menstruation a female, you know, has. The first menstruation that a female has. That one will occur when the child reaches puberty, and the first menstruation is called menarche. Then menopause is the period when the menstruation ceases in a woman. It's not menstruating again, telling the woman that all the reproductive organs, especially ovary, is dead. Cannot produce estrogen, cannot produce ovum, cannot produce progesterone again. So this is the menopause. Then there's another term, climacteric. Climacteric is the period from menarche to menopause. The changes that are occurring from menarche to menopause. I hope I'm talking. Hello? So these are the times that we need to talk about. Then what about the clinical aspect of menstruation? Okay, we have talked about it. Menarche is the first menstruation of a girl. I've mentioned that. And it occurs at the age of 12 to 13 years. Although it may occur as early as 10 years or as late as 16 years in some girls. And puberty refers to the period of life during which the reproductive organs develop and reach maturity, which is from childhood to sexual maturity. And in female, the first signs are breast development and appearance of a pubic hair. The body grows considerably and takes on the female shape. Puberty culminates in the onset of menstruation. If a girl does not reach puberty, it cannot menstruate. And the first few cycles are not usually accompanied by ovulation. Hello? So that is all about that. That is all about that. We've been able to discuss, we discussed ovarian cycle, ovulation, ovarian ovum, menstruation, and menarche. I believe we have also fertilized ovum or fertilization. We have talked about that. How it happens, where it happens, and when it happens. Next slide. So let's now go to placenta and newborn. You know, earlier on that I told you the blastocyst, when it stumbled into the endometrial lining of the uterus. Lest I forget. As soon as the blastocyst stumbles into the uterus, the endometrium is no longer called endometrium. It is called the sudia. Hello? It is called the sudia. As soon as the blastocyst, the embedment takes place, then the endometrium is called the sudia. Note that, please. Then, we want to talk about development of placenta. I said that, you know, when the morula, when the fluid is inside it, if the cluster of cell will be formed, one goes to one pole, the other one goes to one pole. The inner mass cell, the other one will form the newborn, the baby, the fetus, and the amnion, while the other one will form the trophoblast, will form the placenta. So, development of placenta. Placenta developed from the trophoblast. As soon as the blastocyst, you know, stumble into that, and then the chorion, the cilia will be formed on the surface of the blastocyst that has been embedded, and this cilia that is forming on these blastocyst is called chorionic. Eventually, this is what will develop into placenta, and this layer will form. This trophoblast will develop into 3 layers, since the trophoblast, cytoplasm, and the mesoderm. Is this trophoblast that will develop really into the placenta, and the cytoplasm is the one that will be secreting human chorionic gonadotrophic hormone. So this development will continue like that until after 3 months, when the mature placenta is formed. And as soon as the mature placenta is formed, it takes over the work of the ovary in producing estrogen and progesterone and every other thing that the baby will need. And it is the one that will be mingled between the mother and the baby, supplying the need of the baby from the mother to the baby in terms of oxygen, in terms of food, in terms of food, nutrient, and other material that the baby will need to survive and to grow. Then the mature placenta. When you talk of the mature placenta, we want to talk about the shape of the placenta, we want to talk about the color, we want to talk about the weight of the placenta. What is the shape of the placenta? It's circular in nature, and the color, you know, this placenta on its own, the mature one has 2 surfaces, the maternal surface and the fetal surface. The maternal surface is reddish in color, and it contains about 60 to 20 lobes divided by features. These lobes contain chorion, and it is dark red in color. The maternal surface is dark red in color, while the fetal surface is whitish in color. And at the fetal surface, the cord is inserted into the center of this fetal surface. It is fetal surface because it's the one that, you know, faces the child, the baby, the newborn. And it is maternal surface is the side, the surface that, you know, that is next to the mother. So the fetal surface, it is covered by the amnion, and it is whitish in color. And inside it, at the center, cord is inserted. And the cord, the blood vessel from the cord, you know, radiate to the edges of the placenta. It is the blood vessel. Inside the cord, you have 2 blood vessels. That is 2 big artery and 1 vein. They are the one, you know, collecting all the necessary, you know, material that the baby will need from the mother to the baby. Then what is the weight of the matured placenta? The weight of the mature placenta is 500 grams, or 1/6 of the baby's weight. 500 grams or 1/6 of the baby's weight. It is not impossible to have the abnormalities of the placenta by the time the placenta is forming, probably due to interference during the time it's forming, probably interference from internal or external. So We have lots of abnormalities, about 4: placenta suzerainta, battle door, circumflata, to mention just a few. I will advise you to go and read over them and note all these abnormalities of the placenta. Then you want to talk about the umbilicals of the cord, or even the normal cord. The normal cord is inserted. You know, I told you that the other time that inner cell mass will form, you know, the placenta and the cord and amni. Then the cord is about 50 centimeters in length, connecting the baby to the placenta. And it is not impossible. It is whitish in color and contains the blood vessels. The blood vessel is the one that's supplying the baby all necessary things. So, and it is not impossible to have abnormalities of the cord too. You have the true knot on the placenta, you have the false knot on the placenta, and you have the accumulation of water jellies on it too. These are the abnormalities of the cord. But the length is 50 centimeters above. Then, number of blood vessels in the cord, 3. 2 big artery, 1 vein. Let's now talk about the newborn. The newborn, I told you the inner muscle will develop into the baby. And development of newborn, I want to sound to you that development also entails about 3 layers. And these 3 layers will form different parts of the baby. In utero, I'm talking of in utero now. The baby is yet to be born. The endoderm, the mesoderm, and these layers, they are the ones they will develop in different parts of the baby, different parts of the baby. And at the end of the day, when the baby is now formed, at the period, the first 3 months of pregnancy, this is the period we call the period of organogenesis. Organogenesis is the period when the every part of the body, the organ and the system of the body are forming in their rudimental stage. And any interference at this stage can lead, can cause congenital of the baby, abnormality for the baby. That is why you normally advise the pregnant woman to take anything, even drug, if anything aside or anything that may injure the formation or that may alter the formation of this baby in the first 3 months of pregnancy. Thereafter, every other thing continues to grow normally, provided the mother take absolute care of herself and do what is necessary to be done. And when the baby is now born, mature baby is now born, then the care of the pregnancy, the care of the labor, and the care of the baby at birth is in the hands of the midwife. You have to ensure the live baby and the live mother. And when the baby is now born, you care for it. The baby has lots of characteristics. You have to, maintain the adaptation of the baby to the extra uterine life. Is the work of the midwife, providing warm environment, prevention of infection, and then feeding of the baby, care of the baby, examination of the baby to detect any abnormality. This one is the work of midwife. You have to be doing it every day until woman is discharged with her baby from the hospital. And you also teach them how these things are done when they get to their different home. Then immunization, every other thing that baby needs to go until the baby is went out of the immunization after a few months. So I want to go back and read about the newborn and the placenta and every other thing. Thank you so much for listening. We have come to the end of the lecture. I would like to welcome questions if there's any.
Hello, everyone. Kayode Owolabi.
Good morning, sir. So thank you very much for the lecture. But I want to ask about the... Hello, ma?
I'm hearing you.
Yes, I want to ask about the involvement of men in midwifery. are we still having involvement of men in midwifery? Is the regulation allowing men to practice involvement of men in midwifery?
Yes, yes.
Men. Is regulation allowing men to practice midwifery in Nigeria?
Yes, yes, you are allowed to. So men have been practicing it.
Okay.
You are allowed to. You are allowed to.
Well?
If you want to, you are allowed to, please.
Also, hello, ma. Also, about midwifery as a distinct profession as well.
What do you say?
I was told that you told us that a midwifery is a distinct profession, different from nursing. It's a distinct and a separate from nursing as well. But I want to ask, is it not distinct from nursing? You said it is distinct from nursing.
It's not distinct from nursing. Get me clear. It's not distinct from nursing. Nursing and midwifery. But what I'm saying is that from the ages, at the beginning of the war, midwifery is the first holistic profession that is first known. Midwifery was the first profession that was established before the nursing. You understand? It's not different from nursing. There are some people, they may not do nursing. They may go in for midwifery alone. You understand? But at the same time, by the time they are doing their midwifery, they will have the LOUTECH of nursing alongside. Because you cannot practice midwifery without the LOUTECH of nursing. Have I answered your question?
Yes, you've answered my question. Please, I want to ask another question before you go. Please, what is the import of a male reproductive system in midwifery? Considering that midwifery principally is to deliver a baby, nurture the baby when they are very young. What's the import of male reproductive system in midwifery?
Male.
The study of midwifery. Reproductive system. The study of male reproductive system. We study it today. It's part of the it's part of it. But I want to ask you if you can give us the specific functions of the follicle stimulating hormone and the luteinizing hormone in the production in spermatogenesis.
And spermatogenesis.
And the other on the this and the ovarian cycle. So there are specific functions of each of those hormones. Thank you very much.
Okay, thank you. I told you that the follicle stimulating hormone and the luteinizing hormone, they are the hormones that are being produced by the anterior pituitary gland. As they are functioning in the menstrual cycle, they are also functioning in the reproductive cycle of the male. They are also influence the testis, seminiferous tubule, to produce the spermatozoa and the interstitial cells of the seminiferous tube to produce the testosterone. So as they are working effectively in female reproductive system, they are also working effectively in the male reproductive system. Have I answered your question?
Yes, except the male reproductive, the importance of male reproductive system. The importance of male reproductive system in midwifery.
The importance of male reproductive system in midwifery.
We studied it as well. Yes.
Yes.
The relation.
If the male, before fertilization could take place, is it the ovum alone that will develop into the fetus? So it's the spermatozoa. No. Sperm will be produced by male, and the female will produce the ovum, and both of them will meet together and become fertilized and become zygote. So if there's no male, can we have procreation? No, procreation will not occur. Then the life will go into an extinct. The world will go into an extinct. There will not be reproduction again. So both male and female are very important in the reproductive system. And you must know how a spermatozoa is forming. You can go back to read your manual. It's there. The step of the spermatozoa. It's only because of time. And because of time, I will have explained everything into detail to you. The step that involve in spermatozoa formation as well as the ovary formation. You understand? Have you gotten it now?
So, Princess, ask a question. Princess. Archeological.
Yeah. Thank you very much, ma, for the lecture. So I just want to find out that I didn't get you mentioned one thing, that during the first trimester of pregnancy, that the woman should not take anything.
Yes.
Does it mean that the routine drugs taken is not safe for the woman?
Of course.
That's one. Then
Hello?
2, you also said a woman whose period is not. Hello, ma.
I'm hearing you.
Yes, ma. Yes, ma. I don't know if you got my first question, ma.
I got the first question. Ask the second
Okay,
question
ma.
so I can answer them together. Ask the second questions. Hello,
Regular, like those who have 30. Yes, ma, I can hear you, ma.
Okay.
Those whose cycle is not regular,
Yes.
that's those with 30 to 35.
Yes.
You said they should calculate their ovulation for 14th day after
No. Don't
the
let me
menstrual.
explain.
I didn't get that part.
Let me explain further. The first part of the question, when you say, where you said the period, the first 3 months of life pregnancy, that the woman shouldn't take any drug. That is normal birth that we are clamoring for now. Normal pregnancy and normal birth. That the first three months of pregnancy, it's been termed the period of organogenesis. You mean organ and genesis. You know, the organs of the body and the genesis. That is the beginning of all these organs. These are the time that these organs, they are forming in their rudimentary form, small form. And any interference from the mother, whether from the external environment or internal environment, may affect this organogenesis in the woman. And by the time it will affect the part that is forming at that particular time, and it may lead to congenital abnormality. It may lead to, not every woman, no. You know, the different what we call it is there. What happens to you may not happen to me. So it may come up, the woman may come up with congenital abnormality, baby. So it is advisable for all the women to stay away from anything injurious during that period. Even the smallest drug. These days we are advising, you know, if you want to give any drug now, you know, we normally give routine anti-malaria. It is given 16 weeks of pregnancy. It is not given before 16 weeks, because that is the period that is very most delicate for that baby in utero. If anything should touch it, the part of the body that is forming that time can come up with congenital abnormalities. Number one,
Thank you.
The second one, you said that any woman, I said that a woman with regular 28-day cycle, ovulation day is 14th day from the beginning of the menstruation. Assuming that my menstruation, I'm 28-day cycle woman, and I start my menstruation today, and I start counting today. 1, 2, 3, 4, 5 to 14. The 14th day is my ovulation day. Have you gotten that one? For any woman that is having, ovulation, that is having cycle, that is more than 28 days, maybe 30, 31, 32, 35. Your ovulation day, you cannot determine that one, but it is certain. You cannot determine it to be the half of that half cycle of that of your cycle, but it is 14th day to the next menstruation. 14th day to the next menstruation. So it can't be 14 days, it can't be 15, so it can be 16 days, it can be 17 days, it can be 18 days, but it's going to be 14th day to the your next menstruation, depending on your cycle. If you have 30-day cycle now, meaning that it is on the probably 16th of your menstruation day that your ovulation will occur. If you count it from the beginning of the menstruation, then you are getting it now. It's your 16th day.
Yes, ma'am. Thank you very much.
Oh, yeah, another one.
Adetula Faith. Adetula Faith. Oluwaseun Agunlaoji.
Yes, sir.
Ask your question.
Can you hear me, sir? Okay. Thank you, sir. Ma, thank you for the lecture, ma. There is something that is confusing to me that I don't really understand. Is the diameters of the fetal skull. I don't really get the explanation on it, the diameter of the fetal skull. And also, my second question is, because I have 7 study sessions in my manual here. I don't know how many study sessions we should be expecting for the exam. Thank you, ma'am.
All the study session that we have discussed, you have your manual. Every study session that you have discussed is what we are going to examine on. So you have to go through them in between lines. That is all. Then when you are talking about the diameter of the fetal skull, I told you you have 2 major things, 2 major diameter, anterior posterior diameter and transverse diameter. Under the anterior posterior diameter, we have about another 6 to 8 diameters. That is sub-occipitobregmatic diameter, which begins from below the occiput to the center of the anterior fontanelle, which is 9.5 centimeter. Is the best, diameter so far. This is the presenting diameter in vertex presentation. Have you gotten that? Then
yes,
there's another sub-occipital, occipitofrontal diameter, which is 10 centimeter from this occiput bone to the frontal bone. Then sub-occipitofrontal diameter below the occiput bone to the frontal bone, which is 11.5 centimeter. Then you have the mentophatica, which is from the chin to the highest point on the vertex. Then you have the mentophatica, which is below the chin. So, that one, the mentophatica is 13.5 centimeters. That is the highest, so far. Then submentophatica, which is also 11.5 centimeter. That is from below the chin to the highest point of the vertex. Then you have the from chin to the frontal centimeter, from the frontal bone, which is face presentation, is also 9.5 centimeter. These are the anteroposterior diameter, longitudinal diameter. Then the transverse diameter, you have the bitemporal diameter, which is 8.2 centimeter. That is from one temporal bone to the other temporal bone. And you also have biparietal diameter. That is from the point of ossification of the parietal bone to the other point of ossification of the parietal, which is 9.5 centimeter too. These are the diameter of the fetal skulls that we have discussed.
Okay. Okay, ma. Thank you, ma.
Are you satisfied? Hello. Are you satisfied with the answer? Okay.
Good morning, ma.
Good morning.
Yes, ma. My question is just a clarification. When you were talking about the secretory phase of the menstrual cycle, you mentioned the hormone. You said the progesterone is the one that plays a role in that phase. But in our manual, we have progesterone and estrogen. So I just want a clarification on
It's
it.
both. I said the both. Estrogen and progesterone. Estrogen will start to work, then joined by progesterone. Both of them are working in all the phases, but it is pronounced. The work of estrogen is pronounced in the proliferative phase. You understand?
Oh,
You're
okay,
welcome.
ma.
Hello, ma. Good morning, ma.
You're welcome. Good morning.
Thank you for your lecture, ma. Please, my question is on the ovarian hormones, ma. You
Okay.
made mention of relaxin as
Yes.
part of the hormone, ma. Please,
Yes.
I want to find out what that the importance of relaxin in a non-pregnant woman, since you related it to pregnancy during the lecture, ma. Does it mean that it doesn't have any role it plays in a non-pregnant female?
You are quite
Thank
right.
you, ma.
You are quite right. It doesn't have much role to play in non-pregnant woman, but it's only come into play during the woman is pregnant, and towards the end of the pregnancy, then relaxin will be produced by the ovary. Thank you.
Thank you very much.
You're welcome.
Next issue too.
Okay, good morning, ma. Thanks for that lecture. So actually I have 3 questions. The first question talks about fertilization. So please, I want you to just give us a brief recap of the stages of fertilization. Then secondly, under the male reproductive system, the satellite cells, I just want you to just give us a brief summary of what they are. Then the third question is about the determining sex selections. So like midwives now, most of the time our patients ask us, okay, if we want a male, what time do you think we can have sex and all those stuffs? Please, I just want your contribution towards that. Thank you.
Let me start from the last questions. From the last questions, these your questions is beyond this stage. You understand? So when you go for your midwifery proper, you will know that. You understand?
Okay.
So
okay.
The second one, the first one, you said I should enlighten you more on the fertilization. Abi?
Yes,
if I may right.
Yes,
fertilization, I told you, occur through fertilization is just the union of the male and female gamete. That is the spermatozoa and ovum. And fertilization usually, take place within 28 to 48 hours. Because if spermatozoa is produced within 48 hours, it can survive within 48 hours. And the ovum, if ovulation takes place, that ovum can survive for 24 hours. So it's between 24 and 48 hours. And it's just the union of the male and female gametes, and which normally occur at the ampulla of the fallopian tube after the sexual intercourse of both male and female. And thereafter, when the zygote is formed, it will start its journey from the fallopian tube to the uterus with the help of cilia that will be wafting it down there. And as it is going, there will be cell division or segmentation. First of all, until the cluster of cell is formed called morula. That one will take about 3 to 4 days. Thereafter, we continue to move. But at a time, it will get a time when the fluid will continue to accumulate inside the morula, dividing the cells into 2, one to each pole. And at this stage, it is called blastocyst. It's at this stage that it will go, it will stumble, it will fall into the uterus. No, for implantation or embedment. Usually 11th day, 11th day after fertilization. Am I speaking?
Yes, ma.
Thank you.
Thank you, ma.
You are welcome.
Ajiboye Eniola.
Thank you for your lecture. Please, I just want to ask, you said the period between menarche and menopause is called what?
Climacteric. Climacteric.
All right, ma'am. Thank you.
CLIMATERIC. Check inside your notes. It's there.
All right. Thank you, ma'am.
You're welcome.
Akata Joy.
Thank you, sir. Good morning, Mark. Thank you for the lecture. I want to ask, what is the significance of this abnormal placenta that you taught us? What is the significance? What's the significance of really knowing it?
Okay.
Yeah.
The significance of this abnormal placenta is that, like battle dog or Sucerenta,
yeah.
By the time you deliver the baby, you deliver the placenta. Part of these, like Sucerenta now, is just an extra load of the placenta that it will retain inside the uterus. So you will not be able to bring it out unless you see the blood vessel that goes into it. That will now tell you that still something is there, is still inside the uterus. But if you don't see it, it will retain there, and the woman will continue to bleed because the uterus will not go into contraction to stop the bleeding because something is still inside the uterus. So it's called placenta retainment, leading to bleeding. And if that is not taken, woman can die through excessive bleeding.
Okay. All right. Thank you, ma.
Adiatu. Odiatu.
Good morning. Thank you for the lecture. Please, I want to ask, probably make a clarification. A woman who has irregular menstruation, say this month you see it at 28 days, next month you see it at 30 days, 32 or so. How will you determine the ovulation?
Well, you're welcome. Thank you. That condition is an obstetric condition that needs to be taken care of, because in that individual you cannot, decide or determine the ovulation day. So far, the menstrual is not regular. Menstruation is not regular, so you cannot determine the ovulation day. So that individual will first of all go and correct that irregularity first. So before she has a regular menstrual cycle, whether long one or short one, before you can determine the ovulation day.
Thank you very much.
You're welcome.
Hello? Good morning, ma. Go ahead with your question.
Okay. I have two questions, ma. Hello?
I'm hearing you.
All right, ma'am.
ahead.
Yes, ma'am. My first question, ma'am, is on the true pelvics, ma'am. On the boundaries of the pelvics, where you talk about the brain.
Okay.
And you give the diameters.
Yes.
And one which we have the anteroposterior diameter of the brain. And there, under it, we have the anatomical conjugate and obstetric conjugate, which the two are having two different measurements, the 12 cm and 11 cm. So I want, and then the conclusion of that, you talk about the true conjugate. So I don't know which of these is the true conjugate. Is it the anteroposterior diameter or the obstetric or the anatomic? So I want the clarification there, ma. Then the second question.
Okay.
Yeah, the second question on the muscles and fascia, you talk the pelvic floor, ma. You talk about the major, pelvic floor. That
pelvic floor muscles.
Talking about the levator ani.
Yes, levator ani muscle.
Yes. So you talk of it that it has three sets of the layer. So, but then after the three measurement, you talk about the superficial muscles of the pelvic floor again, which there are 5. So I want to know, ma, the three major ones, are they the one when we talk about the levator ani muscle, or including the superficial muscle that is listed the 5? So I need the clarity here, ma.
Okay, let me start from the last one. That is the levator ani muscles. I told you that the muscles of the pelvic floor muscle, there are two. There are two major things. The superficial one and the deep one. The superficial ones are the ones that are the outermost. And there are 5 in number, which I mentioned. Abi?
Okay.
Cavernous, ischio-cavernous, Abi? Perineum, and so on and so forth. There are 5 in number. I said you should know their insertion because they are the ones that are outermost. Then the deep pelvic muscles, they are also called levator ani. Do you get what I'm saying? They are also called levator ani because they are the ones that are going up and down during the time the woman is going during the labor. They go up and down to allow the baby to get out. That is what we call it levator ani. Anything lever, lifting up is lever. So ani. Ani is muscle. Levator is something that's lifted up. You understand? So, and these levator ani or deep pelvic muscle, there are 3 in number.
Yes.
Iliococcygeus muscle, beginning from the ilium muscle and being inserted into the coccybone. Then ischio-coccygeal muscle, starting from the ischium bone and being inserted into the coccybone. Then pubococcygeus muscle, starting from the pubic bone and being inserted to the coccygeal muscles. So these are the deep or levator ani muscle. You can see that they can call them levator ani muscle or deep pelvic muscle. But superficial on its own, they are the one outermost. They are different from this. They are sheets of bone. So fascia has divided them, separated the superficial from the deep. But they are all working together to ensure that the baby pass through them without any injury. Are you clear with that? Are you clear with that?
Yes, ma'am.
The second question, I mean the first questions now. I can't remember it.
Yes, talking about the true conjugate, ma'am.
There's nothing like true conjugate. You have obstetrical conjugate or
anatomical.
Anatomic conjugate or obstetrical conjugate. Anatomic conjugate. If you want to measure it, right? That one is being done during the time that we'll be doing pelvic assessments. You understand? But you cannot understand it now unless I tell you, I explain, I describe or I show you the way it is done. When you measure anatomic conjugate, you measure from the pubic inferior layer of the pubic bone towards the sacral promontory. That one will give you about 30 centimeters. And when you remove 2 centimeters from it, it will give you 11 centimeters. So obstetrical 11 centimeters that it gives you is obstetrical conjugate.
conjugate.
That is the area where the baby will pass through. But with the anatomical conjugate, baby will not pass through that place. But the obstetric conjugate, which is 11 centimeter, the baby will be 11 to 12 centimeter. That is the pathway that the baby will turn when it's coming out. You have anatomical conjugate and obstetrical conjugate. So from the anatomical conjugate, you can get obstetrical conjugate by removing 2 centimeters from it. It will give you 11 to 12 centimeters. Have you gotten it now? Are you there? Anything?
The last question.
Yes.
Ajayi Omobosede.
Thank you very much for the lecture, ma. The Lord will keep blessing the fountain of your knowledge. Ma, my question is this: for those of us that have a single harem,
yes,
and probably post basics in some other fields,
okay,
are now interested in having our harem,
yes,
I want to find out if it's very possible for us to write our nursing council. And I also want to find out if this course, we are going to be doing this course in 400 or 500 level. That's my question.
Let me start from the last question. You are still going to do the course in 400 and 500 level. But the other one, whether you can have it done at OGL or not, I cannot answer that unless you direct the question to the management of OGL. You understand?
Okay, ma, I also, sorry, ma, I also want to ask if what we have, what this entails, this course is sufficient enough for us to write an RM exam.
RN exam? Where? What do you have right now?
Yes.
You have RN exam?
What I'm saying is that this course, what it entails, you said we are going to be doing it in 400 and probably 500 level.
Yes.
I'm not asking that, is this sufficient to write? Because I know RM can also be very tough. What it entails, I don't know the course outline for the next few sections we'll be having.
Okay.
What my question is that the detail, is it enough for us to sit for an RM exam?
In the where? At the OGL or where?
OGL, yes, OGL, yes.
All right. Thank you for the question. Are you with me? Hello?
Hello, sir.
Thanks for the question. The midwifery content of OGL is not the total or everything that you will need to write midwifery exam. Are you with me?
Yes,
this
sir.
is the way it's going to go. If you are eligible for midwifery exam at the end of the day, because there's going to be a selection exam, and depending on the space given to us from the faculty of the number of students we should present for the midwifery exam, then you have to go back to the department, and you are not going to spend less than 6 months with them in the department for you to have a concentrated lecture. So most of the things that will have been taught in ODL will be reviewed. Some other things will be added to it from the department, and with that, you will be sure that you can sit for the midwifery exam and you will pass.
Okay, all right. Thank you very much, sir.
Are you satisfied?
Yes, sir. Thank you, sir.
Okay, thank you. We have come to the end of the lecture. So if you have any further questions, you can contact your facilitator through the WhatsApp or through other social means. So thank you, and God bless you.